Welcome to Searchlight at Eastern State Penitentiary Historic Site in Philadelphia, Pennsylvania. My name is Matt Murphy and I will be your host. Tonight's conversation is about the debate surrounding the effort to prioritize incarcerated people for the forthcoming COVID-19 vaccinations. But before we dive in, a brief review of the state of the pandemic inside American prisons, a very quick intro to the history of Eastern State, and then I'll introduce our panelists and start the conversation. As of January 27th, there have been nearly 400,000 reported cases of COVID-19 among incarcerated people, and over 2,100 people have died from the virus. Incarcerated people. More than 80,000 prison staff have been infected, and there's been more than 130 deaths among prison staff. That data comes to us from the UCLA Law COVID-19 Behind Bars Data Project, and surely the numbers have increased since this data was tapped nearly a week ago. Eastern State Penitentiary opened in 1829 and quickly became the most famous prison in the world. It was known for its radial design, which influenced the architecture of hundreds of prisons around the world. The founders believed that prisoners could be rehabilitated through solitary confinement paired with vocational and moral instruction. They called this the Pennsylvania system or the separate system. This experiment with mass solitary confinement continued for over 80 years and affected the lives of thousands of men, women, and children until the prison abandoned the Pennsylvania system in the year 1913 and replaced it with a more modern congregate system. Eastern State Penitentiary closed in 1971 and was abandoned for over 20 years before opening as a historic site and museum in 1994. Today, Eastern State's mission is to interpret the history of American criminal justice reform. We do this through innovative and award-winning exhibits like the Big Graph, which is a 16-foot high, three-dimensional bar graph on the prison's baseball field. The graph tracks the rate of incarceration in the US over the last century. It also compares the US rate of incarceration with nearly every country in the world. Finally, the graph highlights the alarmingly disproportionate rates of incarceration among Black and Latino people in the United States. The Big Graph has a complementary exhibit titled Prisons Today, Questions in the Age of Mass Incarceration. This exhibit dives deeper into these critical issues and asks visitors to consider their relationship to the criminal justice system. We've been making the most of the quarantine by creating lots of great virtual programming, like Prisons in the Pandemic, a weekly 3-minute news roundup about COVID and its impact on incarcerated people. It's posted every Friday on our Facebook page. Check it out and stay informed. If you believe in the work we do and want to connect more, consider becoming a member. A membership supports our mission and offers lots of exclusive perks, including invites to special programs like Member Saturday. This month's Member Saturday is titled Past and Present, Women and Incarceration. Sure to be a great program. You can stay connected to Eastern State through Facebook, Twitter, and Instagram, and of course our website, easternstate.org. Lots of great programming and free resources there. Don't miss our next Searchlight, which will be March 2nd. Our next Searchlight will continue tonight's conversation in many ways. It's titled Living in Prison During COVID-19. Prisons and jails are experiencing infection rates up to 5 times that of the general public. What's life like for people living in these crowded, increasingly infected institutions? 2 members of the Pennsylvania Institutional Law Project team present a new animated film featuring the literal voices of incarcerated Pennsylvanians reflecting on this critical moment. So we'll be inviting Sue Mignet, who's the executive director of the Pennsylvania Institutional Law Project, and Chester Holman III, a legal assistant at the Pennsylvania Institutional Law Project. So make sure to tune in next month. Searchlight is always free. It's an hour long, and it's always on the first Tuesday of every month at 6 p.m. Eastern Standard Time. Tonight, we're going to be talking again about the debate concerning when incarcerated people should receive the COVID-19 vaccine. Joining us for our conversation is Dr. Hadar Aviram. Dr. Aviram is the Thomas Miller Professor at UC Hastings College of Law. She holds law and criminology degrees from Hebrew University of Jerusalem and a PhD in jurisprudence and social policy from UC Berkeley. Her popular blog, California Correctional Crisis, covers crime and punishment in California. Also with us is Dr. Peter Chin Hong. Dr. Chin Hong specializes in treating infectious diseases. He earned his undergraduate and medical degrees from Brown University. In addition to patient care, Chin Hong is Associate Director of the UCSF Clinical and Translational Science Institute's pre-doctoral research fellowship programs. Thank you both so much for joining us. And a final note about tonight's program, we'll also hear from people currently incarcerated inside Pennsylvania prisons. These folks have provided their opinions and perspectives on the COVID vaccine to us through a written questionnaire, and the responses will help structure our conversation. In Eastern State, I have to point out, is a very appropriate venue for this conversation. Tuberculosis, often known in the 19th century as the convict's friend, was the single greatest cause of death at Eastern State, killing approximately 600 prisoners. The dark, dank, and crowded conditions served as an excellent incubator for the disease. Prison officials eventually transformed Cell Block 3 into a modern hospital to battle the epidemic, including the construction of special solarium or sunroom cells and special exercise yards for prisoners suffering from TB. The prison also battled outbreaks of smallpox, typhoid, typhus. It also weathered the 1918 Spanish flu epidemic. So pandemics in prisons are nothing new, and hopefully tonight's conversation will provide a better understanding of why exactly that is and what we need to do to move forward. So with that, let's jump into our conversation. Dr. Aviram, can you start us off? Can you briefly summarize the debate surrounding the COVID vaccine for prisoners, when exactly they should receive the vaccine?
Certainly. Thank you so much for having me on the program. I think the best way to understand the debate about vaccinating people who are incarcerated in prison is to look at it as being sort of at the crossroad of two struggles, the moral struggle and the geographic struggle. So the moral struggle is all about the question of whether we allocate proper treatment, proper health care to people on the basis of health considerations. We know that the pandemic is disproportionately affecting prisons. We know they get infected at a higher rate. We know that mortality is higher when it's age adjusted because people in prison are younger than people outside on average. Or whether we bring in considerations that have nothing to do with health and have more to do with who the public perceives as being more deserving of receiving good health care. And then there's also this other conversation, which is geographic, and that has to do with whether we perceive prisons as being separate from our communities or as part of our communities. And what's the role of prisons in general in the map of outbreaks and infections that happen in the outside communities? And I suspect that a lot of the objection to prioritizing incarcerated people on the list of people receiving the vaccines come from injecting moral concerns and from misunderstanding how geography operates and how prisons operate.
There's a lot in there that I think we're going to touch on tonight, so thank you for that. But before we dive deeper into some of that, Dr. Chin Hong, I briefly mentioned the many infectious diseases that impacted Eastern State historically. Can you tell us a bit more about why prisons are such excellent incubators for infectious diseases?
Yeah, so if you were SARS-CoV-2, the virus that causes COVID-19, you'd be thrilled to be in a prison. There are a lot of people close together, essentially a lot of noses and mouths close together. So if you go back to the biology of the virus and how it's transmitted, it's mainly through droplets, and that's really between somebody's nose and mouth going to somebody else's nose and mouth. So the more people you have together, the more likely that is to happen. So that's one thing, proximity. The second issue is, of course, ability to protect oneself. And you can be close, but maybe able to cover your nose and mouth, have adequate supplies where you can keep your hands safe so you don't transmit something from your nose and mouth to somebody else's nose and mouth. And that's been in short supply in many of our prison facilities in the US for much of the pandemic. And the third issue, which is probably one of the most salient issues in prisons, is ventilation. So early in the pandemic, we heard about 3 W's you can use to protect yourself. Wearing your mask, which I said is hard to sometimes get by in many prisons. Washing your hands, again, with alcohol sanitizers not really allowed in many facilities, it's very, very difficult, even for donations of supplies to inmates. And then watching your distance. We talked about that not being very difficult to do in a prison. But the fourth issue, which is watching the wind, because ventilation is so important, has really emphasized why there have been so many outbreaks in prisons. If you look at San Quentin and many other facilities in my own state, California, many of them have been built so long ago without robust ventilation systems. And that's a recipe for disaster. If you think about how you can give droplets superpowers, you shout, you scream. These are all activities that are common in prisons. They remain suspended in the air, poor ventilation. It's a recipe for disaster. It's no surprise that so many people have become infected in the prison system.
Yeah, you're making me think about New York State with your comment about hand sanitizer, where prisoners are actually being put to work producing the hand sanitizer, but often don't have access to the product themselves. So kind of a weird dichotomy there. And you're also making me think about Eastern State again, as San Quentin, built only about a decade and a half after Eastern State and still operating. So we asked incarcerated people inside if they think that they should be prioritized in receiving the vaccine. And I'd like to provide one response. Lee, who actually, interestingly, recently had his sentence commuted, answered, quote, "Prisoners should be a priority in receiving the vaccine. Why? Because we are a vulnerable population. Every aspect of our lives is out of our control. Even if we follow every prevention protocol, wear a mask, wash hands, social distance, we are still at a high risk of getting the virus because we are trapped in the conditions of our confinement." Would either of you like to respond to this statement? Why exactly should prisoners be high priority for the vaccine?
I can start. So there are many reasons why we should prioritize prisoners and incarcerated people. A big part of this is also understanding that people who are in prison, just by virtue of having been incarcerated, are already vulnerable. We tend to sentence not only many people to prison, but also people to incredibly long sentences. And that means that we have a surprising number of people who are aging. In California, I think about a third of our current prison population are people over 50. This is an interesting age because on one hand, these are people who, based on everything we know from criminology, have long ago aged out of violent crime. So they actually pose a lot less risk of reoffending if they go outside than the outside population. And at the same time, living in prison for decades makes you very vulnerable and ages you long before you would have aged on the outside. So we're already talking about people who are medically vulnerable. There's also the fact, I think, that at least in California, and I know other states are thinking about this too, there is an effort toward equity in distributing the vaccine. We know that COVID-19 has been a very impactful teacher, not a kind teacher, but it's taught us a lot about social inequality and about who is at the front lines of getting sick when some calamity like this hits. And there is nobody who exemplifies this more than incarcerated populations, being at the very forefront of getting sick and of receiving flawed healthcare. So this is also not only an important prevention issue, but also an important equity issue. And finally, which I hope we'll talk about more later, incarceration and prisons, basically confinement facilities, also act as petri dishes for COVID-19. So basically what we're doing is we're incubating this disease in various places within a variety of counties. And there is a correlation between outbreak in prisons and outbreaks in the outside community. So it's crucial to vaccinate people in these places because the worst thing we can do for everybody inside and outside is to incubate this disease.
Peter, I'd like to talk a little bit exactly the specifics of prisoners' pre-existing conditions, and then I'd like to go back to this issue of geography. So Peter, can you tell us what exactly are some of the common pre-existing conditions among the incarcerated that make them vulnerable? Comorbidities, I believe is the right term.
Yeah, so probably the most, like what Hadar was saying, probably the easiest thing to understand since we're on age with vaccinations now is the age. I mean, if you forget the comorbidities, and that adds the extra spice to making people who are older even do more poorly. So this is on top of age. I think the lowest hanging fruit to start off with is age. every decade you get above the age of 50, you increase your chances of dying from COVID. And we know that particularly in San Quentin on death row, for example, there, the average age is well, above 60, 70. You're going based on what Harari was saying with these incredibly long sentences. So that is very compelling to me. And the proportion of people being that old, just period, increases the risk of people dying. We're just talking about deaths here, not even infections in prison. So right now, even based on what we have in the United States, the risk of dying from COVID, prison versus not, is at least twice or more. So add the comorbidities on top of that, and you're just increasing that risk beyond the age. So diabetes, heart disease, lung disease, these are all risk factors for dying. And also minority populations, which are, a very common, big part of correctional facilities, increased risk of dying beyond the comorbidities and age. So you can put together all of these factors, and you can imagine that's a perfect storm.
Thank you for that, Peter. So the issue of geography, Hadar, can you tell me how the location of these facilities, their proximity or lack of proximity to a community matters, why it matters?
So this is where it's important to correct a misperception that many people have about prisons. We think about prisons as places where we lock people away so that we can be safe from them, and as closed places. Nothing could be farther than the truth. Every day, thousands of people come in and out of prisons and jail going into the community. Staff, visitors, volunteers, workers, people delivering items into the prison or out of the prison. So there is actually constant movement in and out. So maybe it's helpful if we sort of supplant this image that we have of this big, iron prison gate more with a mesh gate, right? And this is exactly what Peter said. From the perspective of a virus, this is actually an ideal environment because it's very easy to move in and out. Now, this is important because prisons have an appreciable and empirically measurable effect on what's going on outside. It's very difficult to talk in terms of a clean causal model because we haven't done any careful contact tracing. This is, I think, one of the major tragedies of the pandemic in prisons, is that nobody took the trouble to do careful contact tracing. But we can show a correlation. I'm currently working on a book about the pandemic with a co-author, and we can show a correlation between spikes in prison and corresponding spikes in the surrounding and neighboring counties that happen a few days later. We see this pretty much everywhere. We've seen this at the locations of the worst outbreaks in California, in Marin County, which surrounds San Quentin Prison, in Lassen County, which surrounds 3 of the biggest prisons in California. We see these spikes happening. It's not difficult to figure out how this happens. All it takes is for a staff member to get out of prison and get takeout on the way home. And then you have a spike in the surrounding county.
And I can't overemphasize that from a medical lens either, because prison health is community health. Because what happens in the prison from a virus perspective is all about community transmission. And we've lived that at UCSF because we took care of people in another county. It wasn't even our county, because Marin County couldn't keep in all of those sick people on their own.
I think one of the major mistakes that we've done is separating the prison from the surrounding counties in terms of decision making. One of the most tragic things we now know about the outbreak in San Quentin, which I think is now widely regarded as one of the worst medical prison disasters in the history of the United States, is that very early on, right after a botched, fateful transfer from a prison of sick people on the bus into San Quentin, the chief medical officer of Marin County actually contacted San Quentin Prison and says, look, we hear that you have infected people that you've just transferred in. Please isolate them. Please test them. This is the health of people in Marin County is at stake. And he was ignored because of this misperception that prison and Marin County operate in different places. Many such mistakes have happened, and this is part of why we find ourselves where we are.
So both of you have worked, you've worked together to bring attention to what's happening at San Quentin. Can you tell us more about the crisis there and what it tells you about the California system and the outbreak at large in prisons?
So maybe I'll start by sharing two things that are unique about San Quentin. San Quentin is different from a lot of prisons in the United States, both in the sense that, like Eastern State, it's a very old prison. San Quentin actually started off as a ship in the 1820s and only became a brick and mortar facility in the 1850s, but most of the buildings in Quentin still date back to the 1850s. And that means that they don't have solid doors, so there's a free flow of air between the cells and outside. There's no adequate ventilation. There's nowhere to put people. So just that the architecture of the prison itself is conducive to very bad things happening. But what San Quentin has going for it, and many prisons in the United States don't, is that it's located smack dab in the middle of the Bay Area, where there's a lot of people who are concerned about prison welfare. There's a lot of political power. There's a lot of attention to what's going on there. So many other prisons who have since had serious outbreaks do not have that same level of pressing advocacy, just because people don't know what's going on there or don't care.
And some of the lessons learned for me from San Quentin were really, you know, speaking to some of the activism that Hadar spoke about as a, healthcare provider, just working with media to bring that to attention. I think, again, with the simple message that prison health is community health, I think that really came to light because of the fact that guards and all the workers from Marin County were getting infected too. I think people saw that connection, and also the fact that we were straining our health system by all the hospitalized people from the facility, because the prison system doesn't have an ICU, it doesn't have acute care hospitals. So who's going to take care of these inmates? It's us in the county. So if people didn't get to the whole social justice aspect of it, for sure they can understand that these resources are common. They're all of our resources, and we needed to work with people to disseminate those messages. So I think that was one. The other aspects to me that was striking was really the powerlessness that was felt not only by the inmates who we think about, but actually by the prison staff, because I didn't report on this a lot because people were worried about their jobs, but the staff there were very afraid of not having enough PPE at the time. Something as simple as a mask or a face shield. I mean, these were very, very locked away, hard to get. Many people in the facilities who worked there didn't want to wear them, so the ones who wore them felt at risk, and they felt very powerless. And I think that was as scary to me as all of the issues that were going on. So, and the third thing I would say, the last lesson for me from San Quentin was, going on the coattails of people like Hadar, working with, as a healthcare provider with public defenders to try to change law or policy was very heartwarming for me throughout the pandemic. But using science as a platform to help influence federal judges or circuit judges, because that was the way in which I can contribute. So I think those were some of the lessons that I learned.
Thank you so much for those thoughtful responses, and I'm glad you brought up staff, and I really want to get to staff and their role in this issue. But before we do that, I want to drill down on the vaccine a little bit. Despite recommendations from public health officials, epidemiologists, most states are not placing prisoners at the top of the list for the vaccine. We talked about the arguments for and against. It really essentially comes down to a moral or ethical claim for people against putting them high on the list. But there is a small group of states, including Delaware, Maryland, Nebraska, and Connecticut, that have prisoners very high on the vaccination list. Do you know, a couple questions. Do you know of any that are placing prisoners at 1A, the highest priority? And is there anything that makes these states stand out? And why are these states doing it so differently?
It's a tough question to ask. I think a lot of it comes down to the political culture of every particular place and how well the advocacy is done in the early stages. I think here, just because we were seeing so much devastation, it was just as soon as a vaccine was on the horizon, it was crystal clear to us that this needs to be the main priority. And I think the other reason why we started advocating so aggressively for the vaccine, and we're doing it through litigation as well as through public advocacy and op-eds, is because we realized that the cavalry wasn't coming. Our hope was that what we were going to do, and this is what would really solve the problem, not just of COVID-19, but other problems, is to just curb the gargantuan appetite for incarcerating people. It's because we've had for so long prisons in California staffed at stuffed at 200% capacity. People started thinking of the fact that now the prisons are only at 100, 105 as a goal. That's not a goal. That's a starting point. If all the prisons in the state are stuffed full and there's not an empty bed in sight, that is the beginning. That is not the end. But it became very clear that we were not getting anywhere with the governor. We were not getting anywhere with the attorney general. The calls to release people, elderly, sick people who are no risk to public safety, were just falling on deaf ears. And that is when it became clear that the advocacy needed to focus on the vaccines. And that's what needed to happen. So I think this is partly why we were successful. I think we also had pretty early on the data because we started running these correlations pretty early on. So we actually had something to show, which is to say, this is not about good guys and bad guys. If people in prison get sick, everybody gets sick. I think that in other places, political cultures are maybe more sensitive to these kinds of morality arguments or deservedness arguments. And I think the people who listen to these kinds of arguments are doing it at their own peril.
Just picking up on the overpopulation issue, when I explain it to people in the community who may not get the idea, it's like if you're in the middle of a pandemic, not only went to a crowded restaurant, but you went to a restaurant where they were packing more diners in. You would never do that. So why should we have folks unprotected in that environment in a prison setting by just making the restaurant like full capacity in the middle of a pandemic? It just seems weird to me.
Should be noted that yours truly tried very hard to get one of the aforementioned state prison systems to participate, and was very unable to make it happen. So interesting to think about. I want to bring in another comment from an incarcerated person in Pennsylvania. Dennis wrote that prisons have vulnerable populations because many of the inmates are elderly and suffer with pre-existing conditions, which we talked about. But moreover, the population depends on staff for its services, the same staff that are carriers of COVID. So can you talk a little bit about the role of staff in this crisis? How are they helping? How are they hurting the problem?
Well, there were many, many credible reports of staff, first of all, like I mentioned, not having access. It wasn't just the inmates. Staff weren't having access to PPE or protections, but also they didn't have that voice because they were afraid. And I'm talking about healthcare providers, staff, people who I knew, who I trained with, not having the voice to speak up that much because they were afraid of losing their jobs. So they were reusing PPE, all of that. Then there's the other issue of a power dynamic in staff. And the people who could enact change were sometimes the ones who were disbelievers, not wearing masks themselves, spreading COVID themselves. So again, power dynamic, lack of, agency, I would say, amongst the staff, and then moving back and forth between the community and the prison setting made these prisoners and in prison individuals not just at risk because they were in a congregate setting, but they are at risk because they couldn't control these people coming back and forth, bringing potential virus to their own setting. So it made it even more, horrific from an infectious disease perspective, you can imagine. So these are all some of the issues. And the fact that we had lots of deaths, not just in inmates, but like you mentioned, Matt, in prison staff, is really heartbreaking because these were probably all preventable on many levels.
And to build on some of the things, I think that many of the things that Peter has said also illustrate the complexity of working with staff on this, because the staff is not a monolith, right? There's lots of constituencies within the staff. And I've had reports of staff that were mocking incarcerated people for wearing masks. I've had situations where people were, their masks were taken away as a punitive device. We've had reports of one prison where the assistant warden was not wearing a mask. The Office of the Inspector General in California issued a report showing photos of staff meetings where nobody's wearing a mask within the prison. And it's really hard to say what's going on. Part of it, I think, is just leadership problems. It's, I think, instructive that only in the last couple of weeks, the attorneys for the guards union have joined the litigation in California. And only recently did they make a video where the secretary of the California Department of Corrections and the president of the guards union are seen receiving the vaccine. And I see this and I'm thinking, well, this is great, but why couldn't this have happened months ago? All of this, leadership and advocacy. So some of this is just the leadership not, coming up, soon enough and doing something about this. Some of this is just improper allocation of staff. As late as June, July, staff were working shifts throughout the prison, so they weren't assigned to particular wings in the prison, and they were basically moving the pandemic from place to place. We now can visibly see, there's a recent Inspector General report that shows how the pandemic moves from wing to wing, and you can only guess it's a staff member moving from place to place. And then you have just compliance problems with the rank and file. And it's difficult to know what's going on. It is true, to be fair, that wearing a mask throughout a long shift is a tall order. Many of us who work from home don't have to wear a mask all day, only when we go outside. So people who work outside in an environment where they have to wear a mask all the time, it's true, it's a tall order. And if you build on top of this ideology, COVID denialism, we know very little about the ideology of the staff. I actually tried to dig this month into finding any surveys of the politics of correctional officers, of, do they believe that COVID is real, even as their colleagues are dying of it? I couldn't find anything helpful. And you would think that the prison would want to know these things if they want to be persuasive. So a lot of these opportunities were lost. And we are now finding out, when we look at the percentage of people who are accepting the vaccine, because in California, at least, we now have data on thousands of people who were offered the vaccine, that the rate of accepting the vaccine among incarcerated people is very high. It's close to 90%. The rate of acceptance among the staff is 33%. And that means there is a problem either with the leadership or with the rank and file or with both.
That's an excellent transition. So I want to talk about attitudes, perceptions of the vaccine, both among incarcerated people and prison staff. So we asked folks inside Pennsylvania prisons, will you take the vaccine when it becomes available? And the vast majority answered that they were willing to take the vaccine. But we did have one response that said no. His name is Eric, and he's currently incarcerated. He said, quote, "No, would want to wait until enough time has passed by to allow scientists to fully study the effects of these vaccines. Study has always shown that it takes years to fully study the effects in which such newly developed vaccine has on the human body. There is no real study of the long-term effects this virus will have." As far as you can tell, how prevalent is reluctance among prisoners and prison staff? What are some of the reasons for that reluctance? Are these reasons any different than the general population? Because we're hearing a lot about reluctance in the general population.
So I would say the data that I've heard is similar to what Hadar was saying, which is a higher than expected aggregate acceptance rate. But there are pockets of vaccine hesitancy, and they really track around, because the prison, on some sense, is a microcosm of what community concerns are. Historically, African-American populations, as you know, have had a hesitancy around medical interventions, research, and I think that tracks into populations there. It's tracking into healthcare worker populations as well, who are of color, not just African-Americans, but some Latinx. I would say, though, it's primarily African-Americans, given the legacy as well as, potential lack of representation in the people doing the science, as well as people interacting with the community. So beyond that, I would say the numbers are surprisingly higher than the general population. And but yes, there's a disconnect between the staff, who's probably more like a nursing home staff population, and we've seen those very similar numbers, 30 to 50% acceptance in some areas. Even first responders like firemen, 50% acceptance. So it's kind of mirroring, probably a little bit lower than some of the other settings like that, but not unexpected. But what's really surprising is the enthusiasm from the inmates to get the vaccinations. They almost like, help us protect ourselves, but also to protect our communities.
I think a big part of the success in garnering so much compliance, and of course, Peter knows better than all of us that any public health intervention is not going to have 100% compliance. You always take any intervention that you do under the assumption that you're not going to be 100% successful. You hope to be as successful as possible. You have to keep in mind that on top of the problems that Peter talked about with incarcerated populations being primarily or predominantly populations of color, which typically have a lot more suspicion about these things, and it's understandable given the background, there is also a horrific legacy of experimentation and non-consensual interventions in correctional settings. And it's not even ancient history like the 1906 experiments that were being done in San Quentin. As recent as 2017, doctors in California prisons were still sterilizing women in California prisons without proper consent. So this is something that was going on until very recently, and people have very traumatic memories of this. And when we were talking to people inside and to people who have been recently released about this, one of the reactions that we got from people who are more hesitant was, I'm not going to take anything from them after what happened to the women. And in fact, we were concerned that even if we were going to encourage, for example, the guards to take the vaccine in front of the prisoners, people would not believe that it's the same substance, like that there was going to be that level of suspicion. I think that the great success that we're seeing in terms of compliance rates on the part of the prisoners can be attributed to several things. First of all, it's to people's credit that in the horrible conditions that they're in, they've been able to be the captains of their own ship and make this important decision, despite the fact that they are not told accurate things inside from everybody. A big part of this is outreach. There's an organization of physicians at University of California, San Francisco called AMEND, which do a lot of important outreach in correctional medicine. They've created a very good frequently asked questions about the vaccine, which has been disseminated widely in facilities. There are a lot of efforts on the part of re-entry organizations and organizations with leadership that is formerly incarcerated itself, people reaching out to their friends, people who actually know friends inside the facilities and say, listen, this is no joke. I'm going to tell you that when it's available to me, I will take it. So it was important that people who have 100% credibility with this population that did not come from the Department of Corrections were communicating a strong pro-vaccine message. And I think this is to a great degree to be credited for what we've seen. I wish we had this kind of persuasive power with the staff.
So I want to talk about logistics a little bit. So we've heard a lot in the news about bottlenecks, supply shortages, communications problems, different approaches in different states. What additional challenges, if any, do prisons and jails present for distributing the vaccine?
I would say one of my concerns is the fact that you need 2 doses and you have to keep very careful registration of who received the first dose. People don't always stay in the same facility. They're not always easy to locate. Part of the reason why so many prison systems in the United States are under federal supervision and have federal receivers is because they don't do a good job keeping paperwork. So this is one of the worries that I have, that maybe inadequate refrigeration for the vaccine that requires refrigeration. And as you've just said, it's issues of chains of supply. We're now experiencing a pretty embarrassing scarcity of vaccines in California. Just a couple of weeks ago in the federal litigation about the prisons, the judge says, well, if we were to vaccinate the entire population of the prison that is what they call COVID naive. COVID naive is someone who hasn't tested positive for the last 90 days. So either they got it or long ago and they've healed now, or they never got it. So if you were to vaccinate those 40,000 people, what would that take? And he said, this is couch cushion money. Like surely the governor can afford to do that, given the enormous boon this can be to the community. The problem is that I'm not even sure that in California we can so easily find 40,000 vaccines at this point.
Yeah, so that's all true what Hadar was saying. I'd also add that the way that the prison health is organized is very different from jail health. Jail health in California tends to track along Department of Public Health's jurisdiction, which is more aligned with how the vaccines are distributed, whereas prison health is a completely different organization, as many of us know, and that comes in from a different track. So it's less aligned, and that's the whole problem why California and other states are having problems with distribution. There are too many streams coming in. There are too many cooks, and public health has been defunded systematically over the last few years. So these are all the bad humors that make it very difficult to distribute. Then there's the numbers issue, like Hadar was saying, but hopefully we'll have a increase in numbers as people ramp up production. We have J&J coming up, which is 1 dose instead of 2, less refrigeration. And the only other comment I would say is that now there's a move to just give everyone as much as possible just 1 shot. If you look at the English data, taking off the beginning pieces of the trial, you could probably get around 80% protection in 1 shot from either Pfizer or Moderna. So just give everybody that 1 shot, and we'll figure out the second shot later, instead of hemming and hawing and waiting for the second shot and keeping it in the storage, because that's not, we'd probably be well into end of 2022 if we kept this up. And we have a race against time. We haven't mentioned the variants yet, but the variants are going to have a potential of upending all of our progress because they're more transmissible. They may not respond to vaccines as well, particularly the South African variant, maybe the Brazilian variant. We have our own California variant, and of course, there's a UK variant. So all of these are very scary. They can make the prisons, again, another hotspot for like explosion of COVID, just because these new COVIDs, they're much stickier. So they're easier to transmit. The viral load, people think it's higher when you get infected. So if we don't do it now, I feel like we're going to regret it.
Peter, I'm sorry if you said this. Has there been a variant detected within any prison system that you know of?
Not that it's been reported, but it would be be foolhardy to think it's not there. We're actually only checking 0.003% of variants in California, samples for variants, meaning that it's just really cherry picking randomly. We don't have the capacity like the UK or Scandinavian countries to systematically look at all our population. I would be shocked, and I'll give you $100, Matt, if there was not a variant in the prison system in California.
I hope I get that $100. I want to talk a little bit about, again, the political side of this at the federal level. So President Joe Biden was sworn in just 2 weeks ago, and his administration has promised to aggressively accelerate the vaccination effort and to ramp up a coordinated federal response. He's also promised action on criminal justice reform. So how do you see things proceeding under the new administration in prisons?
I think one of the things I'm really hoping for is, first of all, to see things that really have an impact rather than things that sound good and impress people. Just recently, there was a flurry of joy after President Biden said that they were going to divest from private prisons. This is not really a cause for joy. Private prisons incarcerate a very small percentage of the prisons in the United States. Pretty much the same litany of horrors that happens in private prisons happens in public prisons. And moreover, the distinction doesn't make a lot of sense because most public facilities are privatized from the inside. The healthcare is privatized, the food is privatized, the transportation is privatized, the utilities are privatized. So the distinction is there's a lot of joy because there's a tendency to make private prisons into the enemy. And really, the problem is way, way bigger than the question of the free market here. If anything, I think what would have made a big difference is to divest from the private sector in immigration detention, where it's a lot more prevalent to use these kinds of private facilities. I think where there could be real contributions to criminal justice reform is to curb the appetite for aggressive drug sentencing on the federal level. This is basically what's packing federal prisons, is just extreme, very inflated federal charges for crimes that are quite adequately dealt with at the state level. So that's one big difference. A major difference would be the issue of immigration reform, which is long waiting. And by the way, this is also directly related to COVID because we are seeing COVID-19 in ICE facilities as well, in detention facilities and federal prisons. So all of those things are directly within the purview of the federal government. The second thing that I think is crucially important is the inspiration and the impact of the new federal administration on what's happening on the state and local level. Because again, it's people tend to overestimate the ability of the president to do criminal justice reform, and they forget that the vast majority of criminal justice doesn't happen at the federal level. It happens at the state and local levels. The states have an enormous amount of autonomy over what's going on. And nonetheless, the president can very cleverly use inducements and partnerships and task forces to create change at the state level as well. So some things that I can see could be useful is, for example, having some sort of synergy about narcotics, about decriminalizing more types of drugs on the federal level, descheduling them while the states continue to legalize, which is a trend we've seen happening for a long time, eliminating the death penalty and eliminating sentences that are basically death penalty de facto, like life without parole or life with parole in places that don't offer parole very quickly. So these very, very long sentences of many decades that are not making anybody safer and cost an enormous amount of money to keep going. So all of those things are things that require a partnership between the federal level and the local level. And I very much hope that people there are thinking across those jurisdictions. There's a rare opportunity of goodwill to do important things on this field, and I would hate to see it squandered and doing just things that sound good or look good and don't actually make an appreciable change.
I just wanted to add something. I hope that at some point prison health becomes reformed, because as what's been evidenced by COVID, there's actually no jurisdiction of the Department of Public Health in the prison health system, which seems nonsensical if you're thinking about a virus that doesn't care if it's in a prison or not in a prison. To have jails be under the Department of Public Health but not prisons just, again, emphasizes how compartmentalized people think about care in the United States.
Thank you so much. We have 2 questions in the chat, so I want to make sure that those get answered. And hopefully we'll have time for one closing question, and then we'll learn about how people can follow your work if they want to learn about what you're up to. So 2 questions from Alicia on Facebook. She says, quote, "We still have Hep C because of prison neglect. How can we get rid of COVID if COVID is not tested and traced with everyone in and out of the facilities?"
So true. I mean, it requires political will and the recognition that, again, simple thought, hard to enact. Prison health is community health. So you have to invest in testing. Just today, somebody was talking to me about what's been going on in parts of Northern California in jails where there's been outbreaks of COVID, but not enough testing. And again, and like Hadar was saying earlier, testing is so intrinsically linked with contact tracing. You need testing to do contact tracing. How can you keep people apart from people who are sick if you're not even looking for it in the first place? So that's a huge limitation in prisons. For example, I'll give you an example. So in this facility in Northern California, you get tested when you come in, you get quarantined in who knows what facility, but then they're quarantining everyone together, but not testing at the end before being put out to the general prison or jail population. So there are multiple flaws in that model, and you can imagine why you can have a transmission hotbed. So if you don't have enough testing, you can't really keep away the people who may be false negative with one test. You need to have sequential testing. Even in the hospital, we noticed that there were patients who are staying here. Everyone's on a mask. We were all protected, but yet there were mini outbreaks. And we needed to figure out, we needed to test not only at entry, but at the longer you stay, you needed to be tested constantly. Because again, like Hadar and I was saying, there's the interaction with the outside and the inside. If you don't keep on testing constantly, you can't go back on your test that you did a month ago as being negative as what's happening right now. So I think the way that testing has been approached has been completely flawed in many of the correctional facilities.
Alicia also asked, how do we get transparency of COVID care behind bars? So how can the public learn what is going on?
So Unfortunately, the answer to that is that what we know about the most shocking horrors of what has happened with COVID-19 has come through newspaper exposés, through the hard work of our friends in the San Francisco Chronicle and the Davis Vanguard and other newspapers that broke stories. And the way they get the information is that our friends and neighbors behind bars at great risk and sacrifice to themselves are getting the story out, which is not easy. There's concerns about retaliation. When there's smuggled cell phones, there's concerns about being found out. Families are sometimes reporting things, again, taking risk of retaliation for their loved ones. And this is how these stories are breaking. We are also learning some of what is going on via litigation, but not everything you hear in litigation is true, because a lot of what happens in litigation is posturing in order to get a right result, and you don't necessarily get a true picture of what's going on. One crucial thing that you can advocate for is to keep the phone service going. Throughout this pandemic, several times, prison systems have suspended phone service, ostensibly because they said that the pandemic was transmitting through the use of the phones. This not only denied people the mental health relief of talking to their loved ones, but it also kept all of us from knowing what was going on. And because of that, every time we learned what was going on, we were quite shocked because the information is so partial. So putting a lot of pressure on your elected officials to put pressure on your prison system to keep the phone lines going, following up on your journalists, encouraging families of incarcerated people to tell what they know and work to eliminate retaliation is key for us to know what is happening.
How else can regular people that are watching this that want to make a difference, that want to help, what else can they do?
Write your elected officials, tweet at your elected officials, raise consciousness of what is going on. Whenever there's a public comment or a town hall in your jurisdiction, go and talk about this, because this is not just about the health of our friends and neighbors that are locked up. This is also about the health of you and your family. It's all the social distancing in the world and all the masks in the world are not going to make this virus die as long as we keep it incubated in our prisons and jails.
Okay, I think one last question. The coronavirus has upended our world. It's highlighted flaws in our workplace and many of our institutions, and especially prisons. So do you think the coronavirus crisis in American prisons will have a long-lasting impact on our system? If so, what kind of changes can we expect to see? Many feel that we are in a reform moment and that the tide is turning on mass incarceration.
You know, Rami Manuel once said in a completely different context, he was talking about the financial crisis of 2008, and he says, you can't waste an opportunity of a good crisis. And I think it's the same here. I think of this virus as one of those, old Zen teachers of yore when they used to, slap the monks into enlightenment. It's not a kind teacher, it's a cruel teacher. It's created so much tragedy, but it's shining a very stark light on what is ugly here. I think one of the moments of awakening for me was actually when Peter and I pretty early on in this crisis were at a press conference together in front of San Quentin. And Peter said, I don't know if you remember this, Peter, you said prisons are incompatible with public health. And if there's anything that proved this, is this virus. Maybe this pandemic is going to go away, but another pandemic is going to come and another pandemic is going to come. It's just locking up so many people as a solution for poverty and deprivation and disaffectation and suffering and substances and homelessness is not a sustainable solution to social problems. And we now have an opportunity to wake up from this nightmare of using locking people up as the solution for a plethora of social problems. The question is, are we really going to take it? Are we going to take this opportunity and look at the mirror and say, we can't keep doing this?
To me, I look at the history that Matt shared early on about Eastern State Penitentiary historic site, and I thought, wow, can we really turn this into a positive light, like Hadar was saying, where you redesigned ways that inmates are housed, and you do this kindly. I know that Amen, the prison group at UCSF, has gone to other countries to try to get other ways of humane medical care within prison systems, and I can only be optimistic and hope that this can turn into something more shining, more brilliant, more hopeful, just like, Eastern State Penitentiary did. I was surprised that all this tuberculosis care was reformed in that way. And it seems so humane. And it seems so starkly in contrast to what I've been experiencing as a healthcare provider, looking at our prison system and COVID.
Well, I think we need to get you two warriors back out there to fight this pandemic. So for folks who are listening and they want to follow your work, what's up next for you guys, and where can they learn more about what you do?
So I've been regularly blogging about what's going on in California prisons and elsewhere at hadarviram.com. I put the link in the chat for those of you viewing this via Zoom. We're also hosting at UC Hastings a symposium about mass incarceration and COVID-19. It starts this Friday. It's going to be 3 consecutive Fridays. I've put the link to register in the chat. For those of you watching this on Facebook, Google UC Hastings Symposium COVID-19 prisons. Please join us. Peter is going to be one of our speakers, but we're also going to have lawyers and activists and formerly incarcerated people. Here I'm going to put my Twitter handle as well. Please don't stay silent. This is a human rights crime, and we all need to do our part.
And like Hadar was saying, it's so amazing what concerned citizens, healthcare providers, everyone can do. We've actually helped enact change, and it seemed like we wouldn't be able to in a clunky, old, antiquated system, but it was possible by using that platform of science in my case, and many people's cases, and humanity. So I hope that we can continue and continue to be encouraged by this.
Thank you so much, everyone, for this super energizing and inspiring and I think optimistic conversation in some ways. And I want to thank everyone who's been attending this conversation, who's been listening to us. And I just want to remind you that Searchlight is every month, the first Tuesday of the month, 6 p.m. Eastern Standard Time. And I think if you like this conversation, I think you're going to like next month's conversation as well. So thank you again for your time, everyone.
Thank you.